Good morning, good afternoon, and good evening, everyone. I'm Katherine Semrau, the Deputy Director at Ariadne Labs, one of the implementing partners of the Momentum Knowledge Accelerator, and I have the honor of facilitating this event. We're so glad that you joined us here this morning to discuss the urgent need for action to save the lives of children around the world. I want to note a few housekeeping items before we begin. So first of all, this webinar is co-hosted by the USAID-funded Momentum Project and the Child Health Task Force. You may ask, what is Momentum? Momentum is a collection of 6 global awards working in 40 countries to improve the health and well-being of individuals, families, and communities with the goal of accelerating the reduction of maternal, newborn, and child death and illness. The Child Health Task Force is a network of global and country-based organizations and individuals working to design and implement child health programs that take a life course approach. We're thrilled to be able to offer this webinar with a simultaneous interpretation for this event from English to French. To access the French interpretation, please click in the link in the chat, or you can find it in the description for this event on the platform that you're using. After you've opened that interpretation link, please close this window, otherwise you're going to hear audio for both events. We're fortunate to have a Francophone guest from Niger speaking during this event, and we will have consecutive interpretation for all the questions directed to him. There's no action needed on your part for this. And finally, we want to share that this event is being recorded. We will send out the recording via our social media channels and email newsletter after the event. Our first speaker today will be Dr. Pavani Ram, the Chief Medical Officer for the Global Health at USAID. After that, our colleague from Johns Hopkins and the Global Financing Facilities, Jennifer Requejo, will give an overview of the global state of child health. And then we'll move on to our moderated discussion panel, and we'll close with those remarks from the Child Health Task Force, Dyness Kasungami. Over to you, Pavani.
Great. Thank you so much, Katherine, and really warm greetings to colleagues and child health champions from around the world. I'm delighted to be part of this exciting event for a discussion on accelerating momentum for child health. USAID has had a privilege and a long history of working on behalf of children and mothers around the world to ensure their survival. And together with countries and partners, I think we are so amazed that to have contributed to achieving more than 50% decline in child mortality since the year 2000. That decrease, according to some analyses that USAID has conducted, have been even more pronounced in countries that have had USAID's high priority funding and support. And so we would like to continue to be part of that story and that historical story. So progress has slowed, though, since the start of the SDG era in the middle of about almost 10 years ago at this point. While fewer than 5 million children died in 2022, children are still dying, mostly from preventable and treatable causes. It's still more than 13,000 children who are dying every day, largely from preventable causes. And we know that 59 countries are considered to be off track to achieve the SDG 3.2 goal of reducing under 5 mortality to 25 or fewer deaths per 1,000 live births. 46 of these off-track countries, or 78%, are in Africa. The causes of child mortality are still preventable. In the first day and the first month of life, these deaths are usually associated with intrapartum complications, complications of preterm birth, asphyxia, small birth weight, low birth weight, and sepsis. From in post-neonatal period, in the 1 to 59 months of life, children are still dying from pneumonia, from diarrhea, and malaria, all of which are still preventable, and for which we have very well-tested and proven tools. These preventable deaths can be addressed with improved access to quality primary health care and preventive and protective interventions, improved vaccination, water and sanitation and hygiene, better nutrition, and the access to timely, quality care for these causes of morbidity and mortality. USAID has shown that we can, with partners, work to address the leading causes and to mitigate the deaths. So strengthening health services, for example, in Kenya, where the USAID-funded Momentum program has worked with the government to ensure the uptake of quality of care standards for child health, and applied selected indicators to monitor that progress in quality of care. Strengthening systems where in Ghana, Mali, Nigeria, and Senegal, collectively, we've made progress in population access to basic drinking water at the household level with a coverage of at least 80%, a critical tool for child survival. Strengthening systems and improving vaccination coverage, for example, in South Sudan, where USAID has supported the development of programs to work in crisis or disruptions from climate and conflict to maintain an upward trajectory since 2019 and showing resilience even during the COVID-19 pandemic. There, we've seen the increase in both coverage of pentavalent vaccine, but also more recently, DPT-3 coverage increasing from 61% to 73% between 2019 and 2023 alone. To accelerate mortality reduction in the next few years, USAID is joining forces with country governments and a coalition of partners for child survival action to highlight the importance of political will and prioritize child-saving related activities from various strategies and initiatives. These efforts to promote optimal health for children must extend from birth to adolescence to guarantee that children survive and thrive. We have more opportunities now than ever, including the recent resolution that was passed at the World Health Assembly on revitalizing commitment for maternal, newborn, and child health. And just 2 weeks ago, the Child Survival Action Partners organizing the event at the WHO Afro 74th Regional Committee meeting to tackle the public health emergency of preventable child mortality in the African region. We know what to do. Let's continue strengthening those systems to provide immunization, to strengthen nutrition, to protect children with quality diagnosis and treatment, and to make sure that no child or mother goes without care due to financial constraints, a lack of political or policy will, and a fragmented approach to implementation. Let's do the right thing, and let's collectively work together to address these solutions. Thanks so much, and look forward to the rest of this event.
Hello, everybody. I'm Jennifer Requejo, and I have the honor of following after Pavani. I am really pleased to be here with you all today to talk about child survival. My few minutes here will be building off of all of the facts and issues that Pavani has already laid out for you. But let's start off with the good news. There has been considerable progress in reducing child mortality in the past 2 decades. As Pavani noted, the annual number of child deaths dropped below 5 million for the first time in 2022. This is great news. However, Pavani also alluded to ongoing disparities in child survival. Unfortunately, where a child is born still largely determines whether she or he will survive childhood. In 2022, approximately 57% of all child deaths occurred in sub-Saharan Africa and 34% in South Asia. Mortality rates are also higher in low-income countries, where children are 13 times more likely to die before the age of 5 than children born in high-income countries. In addition, children who live in fragile and conflict-affected countries are especially vulnerable. Almost half of all child deaths in 2022 occurred in these settings. Inequalities in child mortality are also pervasive within countries. There is huge variation in child mortality levels across subnational regions, between urban and rural areas, and by household wealth. The poorest children in all countries remain disproportionately at greater risk of death than others. Pavani also touched upon the leading causes of child deaths, and she noted that most of them are preventable or treatable with existing interventions and strategies. 4 of the top 5 causes of death in children after the newborn period are of infectious disease origin. All of these lower respiratory infections, diarrhea, malaria, and measles are conditions that are typically associated with poverty. And they are all conditions that can be addressed through basic primary health care and strategies like IMCI and ICCM, both of which we will hear about later today. The leading causes of neonatal deaths, as Pavani pointed out, are preterm birth complications, intrapartum related events, and congenital abnormalities. These are causes that often require more intensive levels of care. Importantly, as child mortality levels in a country begin to fall, the proportion of child deaths increasingly shifts to the neonatal period. Countries need to plan for the health system implications of this shift as they make progress. So they need to both have the resources available to deliver primary healthcare interventions to all children, while also building up their health facilities to be able to deliver high quality childbirth and postnatal care services, including emergency care. We've also witnessed at the same time as these very important and impressive mortality declines, improvements in children's nutritional status. Globally, stunting levels have steadily decreased over the past 2 decades. However, this condition still affected an estimated 148 million children in 2022. Almost 95% of these children live in Asia or Africa. So you can see the growing concentration of these kinds of conditions, mortality and malnutrition, in the 2 regions of Asia and Africa. Child wasting is a life-threatening condition. In 2022, approximately 45 million children under the age of 5 suffered from wasting, starkly elevating their risk of death. Again, over 3/4 of these children lived in Asia and another 22% lived in Africa. Although these statistics may seem daunting, we know what to do to improve them, and there have been some very important promising shifts. For one, as Pavani noted, a resolution was adopted at the last World Health Assembly reflecting renewed global political commitment to maternal and child survival. This is really an important shift that's occurred. The Declaration of Astana in 2018 similarly refocused global efforts on primary healthcare to ensure everyone's, including children's, right to health. The 3 dimensions of the primary healthcare model are all critical to child survival. So starting off, strengthening country health systems to deliver integrated care for children is absolutely essential. Currently, however, coverage levels of basic interventions are still way too low in many countries. Although immunization services globally have exceeded about 80%, millions of children are still not receiving any vaccinations, and we must address that gap. Coverage of interventions for other leading killers of children, like pneumonia, diarrhea, and malaria, is often below 50% in countries. If these services could be scaled up at an affordable cost for families, many children's lives would be saved. Another really important event that has recently occurred is the launch of the Community Health Delivery Partnership, which holds great promise for coordinated action to improve community health programs in low and middle income countries. This is a key strategy for increasing families' access to needed child health services. Coordinated multi-sectoral actions are also needed for children. For example, as Pavani already talked about the critical importance of water and sanitation, these are foundational to preventing childhood diarrhea and other infections that can lead to mortality and significant morbidity. We are still far behind in reaching universal coverage of these services, particularly in urban slums and in remote rural contexts in low and middle income settings. Also, ensuring families have access to sufficient nutritious foods by strengthening food systems and agricultural practices would go a long way to addressing very concerning rising levels of food insecurity in many contexts. And this could also really help with reducing childhood malnutrition. which underpins about half of all child deaths. The third prong of the primary healthcare model, community engagement and local leadership, are also essential for ensuring child health programs reflect local needs and for holding governments to account for providing these programs to all children, regardless of where they live. We will get to hear more from our guests today on country examples of success and on additional ways we can improve children's lives around the world. They show us what is possible when we work together. I thank you very much for the opportunity to speak with you today. And now I'm looking forward to hearing from the other panelists and talking more about child survival. Thank you.
Wonderful. Thank you so much, Pavani and Jennifer, for framing the challenges that we're facing and highlighting the opportunities that we have to make change. And like Jennifer said, we're about to hear from several esteemed panelists who are putting these interventions into action. First, we have Dr. Lynda Farma-Grant, Program Manager for Child Health and the Expanded Program for Immunization at the Sierra Leone Ministry of Health. We're also going to hear from Yared Tadesse, Newborn and Child Health Advisor for USAID's Quality Healthcare Activity in Ethiopia. We're also fortunate to have today joining us the Honorable Elhadji Bozari Amadou Sabo, who is the Town Chief for Arewa in Niger. Bienvenue. And Jennifer, again, who we just heard from, is going to join us as a panelist for this portion as well. So first of all, Yared, we're going to start with you. We hear that Ethiopia has made significant strides for child health, reducing child mortality by half since 2000. And that makes Ethiopia one of the few countries that's on track to meet the Child Health Sustainable Development Goals. We'd love to hear from you. How has this been accomplished? And what advice would you give to countries that are struggling to meet that child health-related SDG? Yared, over to you.
Thank you, Katherine. Can you hear me, please?
Yes, we can.
So thank you for inviting me to share the experience from Ethiopia on the reduction of under 5 mortality, which is really a long path starting from the early millennium 2000 up to 2020 and 24. So Ethiopia was one of the highest countries, the highest child mortality rate or high child death burden countries during the early millennium years. However, with the introduction of development-led child health interventions, it was possible to significantly reduce the under 5 mortality rate. It used to be around 166 per thousand in the early 2000s. Now we have an estimate of 47 per thousand under 5 mortality in Ethiopia in 2024, according to the interagency estimate. So we cannot separate really child survival from development agenda. So the country was able to reduce this high burden of child and neonatal mortality due to the many interventions and approach that I'm going to mention in few minutes. This is a very long journey in a very few minutes that I'm going to share. So the first is the macro level development. So we cannot separate development from child survival. So the high economic growth and the significant poverty reduction that the country has registered over the past 2 decades has significantly contributed to the health gains in Ethiopia. It had also implemented multi-sectoral policies, strong coordination across many development sectors, such as poverty reduction, education, nutrition, sectors of transportation, water, sanitation, and hygiene, which are very, very vital for preventive measures or interventions to reduce child mortality. So they have contributed significantly to the gains that Ethiopia has made. The other is the comprehensive governance and planning that Ethiopia had followed for the past 2 decades at least. So Ethiopia has developed and implemented a comprehensive 20 years health sector development plan. And for the past 5 years, we have been implementing the health sector transformation plan. So these plans, especially in the early 2000s, they focused on the what we call the health extension program. This is the backbone of the child health intervention to make life-saving interventions accessible to the rural communities of Ethiopia. So in 2003, following the launching of the Community Health Extension Program, there was a dramatic improvement in access to newborn and child health services across the country, especially in the rural areas. So the focus has been given really to the reproductive, maternal, newborn and child health in these sector development programs and health transformation agendas. So more or less, maternal and child health were at the center of the health transformation of the Ethiopian health system for the last 2 decades. So this has been one of the major game changers in the country's reduction in child mortality. The other is the massive infrastructure, expansion, including improving the readiness of health facilities to provide newborn and child health interventions. So over the past 20 years, there was a massive expansion of health infrastructure, improving the functionality of health facilities like health posts, health centers, and health, hospitals. And due to these interventions, due to these investments, the health facility density has improved significantly between 2000 and 2020. If we look into the health post density alone, it improved threefold between 2005 and 2020. This is along the readiness also includes a massive improvement in health workforce training and deployment of health workforce, nurses, midwives, health officers, and medical doctors. And also it included the improvement in supply and uptake of life-saving child health commodities, which are really essential for the integrated community care, newborn and management of newborn and child illness, what we call the ICMNCI, and the integrated management of newborn and child illness, IMNCI. So the supplies, commodities, which were available for free at health posts and health centers have also improved the uptake of newborn and child health services at the community and health facility level. We cannot also forget to talk about the funding, the health funding, which we got or received from our international donors, and also the expenditure from the government, which has also significantly grown in the past 2 decades. So the total health expenditure has also improved as compared to from the percentage in gross domestic product increased at least twofold between 1995 and 2020. So the funding from the external sources, especially development partners, really increased by 5-fold between 1995 and 2010. So the investment in terms of funding was significantly improved during the last 2 decades. The other is, as you know, the social determinants of health. The country, through its multi-sectoral approach, has improved a lot in its social determinants, where there were improvements in female literacy, there were improvements in fertility reductions from 6 to 4.1 per woman, children per woman during the last 20 years. So this was also a major contributor to the progress of survival of mothers and children. When we come to the health workforce, the health workforce also massively expanded. There were, as I tried to mention earlier, the training and deployment of health professionals, especially beginning from 2003. We had the deployment of more than 16,000, nearly 32,000, health extension workers, 2 per health post, and we have around 16 to 17,000 health posts in the country. So starting from 2003, there was a massive training and deployment of nurses, midwives, health officers, and also medical doctors. So this significantly improved the service coverage of these life-saving interventions, essential newborn care, IMNCI, ICCM, and CBNC. And the health extension workers were vital in improving access to the rural community of life-saving newborn and child health programs. So apart from the curative services, they also supported or provided preventive and promotive interventions when it comes to WASH, nutrition, and immunization interventions. The last but not least is partnership. We had strong partnerships with development partners. This cannot or could not be achieved without the generous financial and technical support of the global partners. They provide supports through planning, implementation, monitoring, and evaluation of newborn and child health services from top to the bottom, to the functional unit of the health system, which is the health post. So this was also one underlying determinant for the contribution or success the country had made throughout the last 2 decades. So data was also one broader investment that we had also done, using data and evidences for prioritization as well as for program monitoring and interventions were very crucial. So advice to other countries, developing countries, would be to design a community-based program like the health extension program, which should be used as a main vehicle to increase the coverage of life-saving newborn and child health interventions rather than having vertical programs when it comes to child health interventions. You know, putting in place multi-sectoral approach without which it is not possible to address nutritional factors, WASH and immunization-related, school health-related interventions. So for this, we need the education sector, the transportation sector, the women and social affairs sector, and the likes. Maybe the other is to improve fundings and domestic resource mobilizations through the government-led coordination and mobilization. This is also one crucial advice that I would recommend, and look into the service inequalities within the country. So even though we have achieved significantly in reduction of under-5 mortality, it is clear that there are subnational inequalities in Ethiopia as well. There are disparities. So countries should look into the disparities and inequalities that exist within and between communities, so that universal coverage, cannot be achieved without reaching the unreached and the most vulnerable segments of the population. So lastly, readiness for health system resilience, where as we all know, we had the recent COVID pandemic, which tested really the health system of most countries. So readiness, early warning, early notification and response mechanism should be in place to prevent shocks for the health system during emergency situations where the most affected segment of the population are children and mothers. Thank you, Katherine. Back to you.
Wonderful, Yared. Thank you so much for such a comprehensive answer. And I think that framing about the wraparound services that are needed, just extremely useful information, I think, for all of us. I think we're going to turn to our colleague from Niger for one moment, who's going to assist us, be assisted by consecutive interpretation. So, Honorable Chief, you lead the town Nduchi in Niger's Dosso region, and in Niger, more than 47% of children under 5 are undernourished. We would welcome the opportunity to learn from you about how your town has addressed the undernutrition in children, and what are other areas that are important for you to address for children's needs in your area. Over to you.
Honorable Chef, vous dirigez la ville d'Arewa dans la région de Dosso au Niger. Au Niger, plus de 47% des enfants de moins de 5 ans sont sous-alimentés. Donc, est-ce que vous pourriez nous parler de comment votre ville a abordé la question de sous-nutrition chez les enfants et quels autres problèmes doivent être résolus pour les enfants de votre région?
Cette question, je m'appelle d'abord Amadou Sabo, chef de canton de l'Arewa, et nous abordons le problème de la malnutrition à travers la sensibilisation. Et cette sensibilisation se fait à travers plusieurs activités. Quand nous faisons l'intronisation, c'est le moment aussi de rassembler nos gens. Donc, on fait la sensibilisation de cette malnutrition qui est une réalité vraiment chez nous. On sait que ça existe. Donc, on fait la sensibilisation à toute occasion qui nous présente, surtout dans les cérémonies religieuses, qui nous permet en tout cas de regrouper plusieurs des centaines de gens. Et aussi, comme on sait que c'est un phénomène qui est dû à l'ignorance et à la pauvreté, donc on est en train toujours de sensibiliser les gens à toute occasion. Et souvent, on fait des caravanes qui regroupent plusieurs villages et faisant grouper beaucoup de centaines de femmes et enfants de tous les leaders religieux. À travers cette caravane, on sensibilise les gens davantage pour juguler ce problème-là. Et aussi, comme il s'agit d'un phénomène qui est aussi lié à la pauvreté, on sensibilise les gens sur les activités génératrices de revenus, AGR, pour toutes les occasions qu'ils représentent. Et aussi, on sensibilise les gens. Tout le monde sait qu'il y a beaucoup de tâches familiales qui sont sur la femme dans notre région. Donc, on les facilite en tout cas l'accès à des moulins pour, en tout cas, faire un peu faciliter la tâche pour occuper aussi de leurs enfants. J'ai même moi...
Un instant pour l'interprétation, s'il vous plaît. So thank you very much. My name is Honorable Elhadji Sabo. I am the village chief of Arewa, and we deal with malnutrition primarily through awareness raising and education, and we do this through several different activities. First of all, when we have gatherings of people, for example, when local village chiefs are being inducted or inaugurated, this is an opportunity where a lot of people come together, and it's a good opportunity for awareness raising. We know that malnutrition is a reality in our region, and so we try to take advantage of every opportunity we can to promote education and raise awareness. We do this during events such as religious ceremonies or other events where there are large crowds of people. We also know that malnutrition is a phenomenon that is due to not only poverty, but also lack of knowledge. So this is why we try to take advantage of every opportunity to educate people. We also do this through activities such as mobile caravans, where we bring together people from many different villages, and this allows us to reach village leaders and thousands of people and to be able to educate them better about services that they can access. And as I said, since this is a phenomenon that is linked to poverty, we also try to promote income generating activities. And we do this at every opportunity. For example, we try to give people access to activities such as establishing grain mills. This is another opportunity to help increase income for them. Vous pouvez continuer, merci.
Toujours dans le même cadre, pour quand même juguler le problème de la malnutrition, j'ai ma propre initiative dont à chaque année, le jour de la journée de la femme, j'offre vraiment gratuitement les semences améliorées, les intrants, et je les forme les femmes les plus démunies, en tout cas dans les villages. Tout ça, là, c'est pour juguler le problème de la pauvreté qui contribue aussi à la malnutrition de nos enfants ou des enfants de notre population.
And so also another way to deal with malnutrition, every year I have led a personal initiative where on the International Women's Day, I provide seeds and other inputs to women who are impoverished in various villages to help them be able to start these mills or other income generating activities. So tackling poverty is another way that we are trying to tackle the issue of malnutrition.
Et sous le même problème, toujours nous sensibilisons la population sur d'autres maladies qui, en tout cas, qui affectent nos enfants, qui sont très dangereux, surtout les palus, la diarrhée, le rhume et d'autres. Et encore, on fait des sensibilisations sur la population pour qu'ils fréquentent les centres de santé pour les CPN, consultation prénatale.
And we also try to educate people about other diseases which contribute to malnutrition as well, such as malaria, diarrhea, and respiratory diseases, which are dangerous diseases as well for our children. And we also work on promoting the idea of accessing healthcare and antenatal care as a way to help combat malnutrition.
Yes. Et aussi, à la vaccination, on sensibilise tous les gens, toujours la vaccination, parce que vaut mieux prévenir que guérir. Et c'est dans cette activité, ce qui nous a marqué aussi, c'est d'aller nous-mêmes, en tant que chef de canton, à la rencontre des chefs de village, à la rencontre des femmes, à la rencontre des leaders religieux, pour les parler de la santé, en tout cas mère et enfant. Ça, c'est une très bonne, en tout cas, information qui y va de l'intérêt, et les gens nous écoutent très bien. Et vraiment, je pense que ça va changer, Inch'Allah, les dons d'un peu d'État. Et la population vient beaucoup si on parle avec eux. Et en deuxième position, aussi des caravanes de sensibilisation qui regroupent plusieurs villages, des centaines de femmes, des centaines de villageois et leurs leaders et des marabouts pour toute cette question de la malnutrition ou de la santé mère-enfant en général.
Another aspect that we try to emphasize is the importance of immunization and trying to educate people about how important this is to help prevent diseases. And we also work with all the different heads, chiefs of the cantons, and we try to work with women in the villages, religious leaders, and talk to them about health issues and the importance of mother-child health. And people have been very receptive. They've really been listening to our messages, and we think that this is going to help bring about a significant change. And I also mentioned the mobile caravans where we do outreach with many villages. This allows us to bring together hundreds of women and village leaders and to be able to talk more about these issues of mother-child health.
Well, thank you very much. Merci, Honorable Chief. Did you have anything else to add?
Merci, Honorable. Est-ce que vous avez quelque chose à ajouter?
Ce que j'ai ajouté, c'est toujours sur la sensibilisation qu'on doit faire, qu'on doit continuer à tout moment, à toute occasion, pour que ce phénomène vraiment doit être jugulé complètement, et surtout combattre l'ignorance et la pauvreté.
I would simply add that I really like to highlight the importance of education and outreach. We really need to continue these efforts at every opportunity so that we can stamp out this whole problem of malnutrition and continue to combat issues of poverty and ignorance.
Merci beaucoup, Honorable Chief. I think we will move to another panelist for one moment, but deeply appreciate the knowledge and insights from Niger, particularly around the focus on education and importance of maternal and child engagement. We next have a question for Dr. Lynda Farma-Grant, the Program Manager for Child Health in Sierra Leone. And we would love to hear from you about what it takes to reduce child mortality and which areas you're focusing on. Over to you, Lynda. Thank you.
Thank you very much for having me. Thank you very much, Katherine. So for us, it was, should I say, a long journey, but things have really progressed. So we've been doing child health, but in a fragmented pattern. Like we have a HIV program, which implements the pediatric HIV. We have malaria, which, it's the #1 cause for child mortality in Sierra Leone. We have the TB and leprosy program. We have the community health program. So they've all been implementing child health, in their own little way. But in the year 2022, when our honorable minister went to the UN General Assembly, and then he made a clarion call to global leaders that, look, we are off track. We acknowledge that, but we need help. And so this was heeded too. And the same year, we have a group of people from USAID, GFF, the Child Health Task Force, UNICEF, WHO, they all came to Sierra Leone. And we did like a system diagnosis. It's good to diagnose patients, but then you don't diagnose yourself. So we did a system diagnosis and did a national kind of dialogue, stakeholder dialogue, and it was clear that there was no central coordinating body bringing all these pieces together to really focus on the child in a holistic manner, because we are now leading on a life stage model, life stage approach, where you take, the patient is in the center, and everything you need to do for that patient at every stage of their life, starting from pregnancy. So that is how the child health program came about. And we are kind of like a year old when we are formally officially launched in the country. So our main task is to actually bring together all these stakeholders. The malaria program, the HIV program. So we have a national TWG, child health TWG, where it brings together partners, MDAs, and programs within the Ministry of Health to really discuss about child health. Yeah, so we even developed the Child Survival Action Plan, and we are the first country to do that. And what did we entail in this Child Survival Action Plan is to diagnose the problem, the systems issues, and how to really go about addressing these bottlenecks, as we called it. And so we developed the Child Survival Action Plan, and we've been implementing that. And also, another important thing was our Minister of Health is championing in the African region's child survival. And he has even gone beyond that to say, we just don't need our children to survive. When they survive, the so what question. We need them to thrive, and we need them to prosper. So we are not just stopping at survival. We need to ensure that these children are thriving. And also, we declared an internal public health emergency for maternal and child death. What that means is whenever a death happens anywhere in the country, be it at the facility level, be it in the community, it is mandatory to report those deaths, and we should review or audit what led to those deaths, a fraction of those deaths. We know children die in huge numbers. So we said, okay, for us not to overwhelm the system, we might not have the capacity. Can we review 2 deaths per week? Because by the time you do that for a couple of months, you might have captured what are almost all the causes when you review these deaths and collate them. And then we are now addressing the issues that are leading to this death. And this is happening for both mother and children. And we have a dashboard. We have a center called the Emergency Operations Center for Maternal and Child Death. When this happens, you have a dashboard to see that where this death happening, and we have a direct call to those districts or to those facilities, what is happening and what they should do to reduce that. And also with the same enthusiasm and the same strategy, our Minister of Health recently, like a few weeks ago, on the 28th of August, during the Afro meeting, the RC 74 in the African region, we had a side event. Sierra Leone hosted a side event together with global partners and the WHO. We hosted a side event wherein our honorable minister, like said, if now we have monkeypox being declared as a global emergency, how many people have died from monkeypox? But then we have millions of African children or children under 5s dying yearly, millions of those children, and majority of them, as we've heard from the opening remarks, are in the African region, the sub-Saharan African region. And we are not declaring child mortality an emergency. This is not, it's such like, where we're declaring one disease an emergency, but then when children are dying in huge numbers, we're not declaring an emergency. So he said, like, this shouldn't be like this. We should declare an emergency on maternal and child death in the region. And the efforts we put together when we combated Ebola, now monkeypox, the resources, the audiences that are coming together to address this should be the same for child mortality and maternal mortality in the region. We should bring national resources. We should bring global and regional resources and fight this as an emergency, because this is also an emergency. And so there was a call to action and ministers of health from the African region were there, and they went to several calls to action, which they approved, that they should prioritize maternal and child survival in national forum, just like to be like presidential flagship in our various countries. So if the presidential flagship is focusing on education, child mortality, maternal mortality should also feature in those policies. And for us, we have one of our flagships for our government, human capital development. And our president has made it clear that children form the basis of human capital development, be it their education, be it their health. So it is the basis. So that has been featured, and we want that to happen across the region, and to ensure accountability at all levels. It's good the future in national policies, but are we putting in the resources? Are we putting in the work? Because we've done the talk. So now it's time to walk the talk. So we need accountability across all levels. And also we need to align investment. Like I said, there's a lot of fragmentations. There's a lot of funding elsewhere. Sometimes, some countries may not utilize all their fund and they have to return it because these fundings are time bound. but then there's need in country. So how can we pull this funding together and also ask our global and regional partners for flexibility? Someone might say, oh, my fund is just for HIV or for TB or for malaria. But then what about malnutrition? What about quality of care? What about infrastructure? What about WASH? We've stated all these issues. So we really want that change in narrative along investment, and also the multi-sectoral collaboration we've had from our Ethiopian colleague, how you need the Minister of Transport to take care of the roads, the maintenance, etc., education to ensure the children are in school and having education, and then the health should do their own part, and advocacy as well, with heads of state as well, CSOs and everyone to prioritize child survival. So far, that is how far Sierra Leone, what child survival is, and how far we've come with implementing it so far. There's still a long way to go. So basically, it's just like a renewed focus to end preventable child death in the region and in our countries. Thank you.
Thank you so much, Dr. Lynda. I think one of the things we're hearing consistently is this idea of multi-sectoral approach, but I have to say, I'm going to steal your phrase. We diagnose the child, but we have to diagnose the system. I think that's a wonderful framing. And actually, one of the things you brought up is about data and how important that was. And actually, both the other speakers from Niger and Ethiopia alluded to this. So I'm going to come to Jennifer Requejo to talk a little bit, building on her expertise in data and what that means. So Jennifer, how does data play into all of this? And how do you use that information to support child action and how we improve our implementation and impact?
Thank you very much for the question. And I agree with you. I really like that framing of how do we diagnose the system? And part of that comes through the use of data. I also really appreciated to hear that Sierra Leone has data dashboards that allow them to get a sense of what's happening on the ground so that they can reprioritize if needed or course correct. So all of that is about data. Data and strong country health information systems are essential for ensuring that we collectively achieve the 2030 goals. High quality data and well-functioning country health information systems are essential for priority setting, planning, monitoring, and course correction of activities at all levels, global, regional, country, and local. At the global level, robust data are essential for tracking progress towards things like the SDGs and other goals that have been set. These data are critical for driving the global health agenda and for helping partners align their actions for children. Plus, many of the issues that are now affecting children's lives are transnational in nature. For example, pandemic preparedness and response efforts, climate change mitigation, and making sure that migrant children are reached with packages of social nutrition and health services all require good global coordination, and all of that should be driven by the latest available evidence. At the regional level, data are critical for identifying economic, political, cultural, and social challenges that may be very common across countries in any given region, as well as for helping at the regional level, designing and monitoring implementation of cross-country efforts to address these challenges. Robust data compiled at the regional level can also foster cross-country learning and sharing that can lead to considerable improvements in children's health in all countries in that region. At country and subnational levels, good data is the cornerstone for country planning. It helps countries to identify strategic directions forward and how they might want to tailor their programs and policies for specific areas that may be falling further behind. For example, if they have some pockets in remote areas where their children are really underserved, or it helps them with identifying specific population groups of children that are not receiving the services that they need to both survive and thrive. For example, countries that have strong civil registration and vital statistics systems help give them basic information for planning. Knowing how many births are happening, for example, is critical for enabling a country to plan and determine the volume of child health services that will be needed and what they need to do to make sure their health system is ready to provide those services. Good data is also key for monitoring program and policy implementation. through existing processes, mechanisms like annual review cycles, midterm reviews. That's all should be really grounded on data. And also, it's also key for, as we just pointed out, with these data dashboards that might be updated in more real time, that also enables countries the ability to adjust as needed if what they're doing to implement a program isn't working so well. Also now, good data is, and I think this is great that this has also come up in some of the previous speakers' comments about accountability. So data is really essential for accountability to happen. We need both independent analyses and regular progress assessments to call countries and all partners out when they are failing to fulfill their commitments to children's health. So that is at all levels again. So at the global level, regional, and country level, partners and country governments need to be held to account when they're not realizing the commitments that they've signed up for. The other important actor here is data is really essential for equipping civil society actors. Timely, high-quality data for civil society organizations enables them to raise their voices when governments are not providing needed services, and to help them strongly advocate for programs and policies that are tailored to local needs and that will reach all children with the services that they deserve. So I think it's really critical that countries and their partners prioritize continued investments in country health information systems and on establishing ways of data sharing that both respect country autonomy while also fostering and enabling cross-country learning so that there can be improved coordination on transnational issues that affect child lives, and also so that countries can learn from their peers on what they did well so that they can also adopt those strategies for their own situations. So thank you, Katherine, back to you.
Excellent. Thank you so much, Jennifer. I mean, it's such a great summary of where we are and what we need in order to create change. And it's hard to believe, but we're actually coming to the end of our hour. I feel like I could talk to you all for another 3 hours to learn more from each of our colleagues. I just want to give gratitude and thanks to everyone for this spirited conversation today, and in particular for hearing about this multi-sectoral approach that doesn't involve just the health system, but the other systems in the country to make it work. And I'd like to close our conversation by having closing remarks by Dyness Kasungami, who's the coordinator for the Child Health Task Force. And Dyness, I'll turn it over to you to close us out. Thank you so much. Dyness, I'm sorry, your mute seems to be on. Do you mind just unmuting and starting again?
Okay, sorry about that. I wanted to thank the speakers who went before me and the panelists for sharing their thoughts, particularly what's happening at the country level. But I also want to thank all those who've joined this event, which we rightly called a moment for children. I want to just recap a few things that the speakers alluded to. The first is the issue of preventable deaths and the fact that we've made progress, but this progress is uneven. Jennifer made a statement that where a child is born determines their probability of survival, and that should not be. To us, these might be statistics, but to the parents of these children and to their families, one death, as Minister Dembi from Sierra Leone likes to say, is too much. So we should not accept this situation, and we need to work hard. So under the Child Health Task Force, we framed the Child Survival Action, working with partners, particularly leaders on the African continent, recognizing that we only have 6 years to 2030. This is an effort to accelerate action and work together in the countries that are off track at the moment. We are encouraged by the fact that despite the challenges with resources, with climate, fragile context, countries are making progress, as we heard already. So how do I summarize some of the key issues that have come out? The issue of equity, of course, that means every country needs to look exactly where the children are dying, who is being reached, who is not being reached, and address those needs appropriately, which is closely tied to data. We can't overemphasize the role of data in making the right decisions about programming, in allocating resources to ensure that we meet these needs, in holding one another accountable for the progress or for lack of progress. So data is going to be at the center of this response. Leadership is also important, and we've seen leadership at the global level as the World Health Assembly adopted the resolution on maternal and child health. We've also seen leadership on the African continent, and rightly so, because the majority of the children that are dying are on the continent. So as already highlighted at the World Health Organization Afro-Regional Committee meeting, African ministers of health adopted a call to action, again reiterating that they need to run faster in order to save these children. Another element of how we're going to come together, which is also emphasized in the child survival action, is partnership. And that this has been restated in all the conversations or the speakers this morning have alluded to the role of partnership, that addressing child deaths is a multi-sectoral issue. So we've heard how nutrition sector, how we need to include infrastructure, because we need a strong road network. We need to bring together community leaders. The Honorable Amadou Sabo from Niger particularly talked about how they are working with the community leaders to bring not only education, but also mobilize action at that level, which is very important. I think we've heard the role of civil society organization, but I'll just add that we also need to think about the private sector where appropriate, and bring them into this strong partnership so that we can work together to save the children. Lastly, and this is an important role of the Child Health Task Force, is learning and sharing. So bring the lessons from the experiences from your country, but also come to learn from how other countries are working to address this issue, so that together we can indeed end preventable child deaths and accelerate progress towards the 2030 target. Thank you again for joining this event. And as already said, the recording will be shared. And we hope that you will continue with these conversations and actions in your countries, and indeed recognizing this as an emergency that requires action. Thank you.